Hearts stop beating, lungs stop filling. Still, you keep going, knowing the road to recovery is paved by those who refuse to rest, bolstered by broad access to advanced technologies, keen on continuous education and real-time training, backed by the support of partners, both at your side and behind the scenes. Proud to be part of an ECLS team that has everything and stops at nothing. Unstoppable.
Good evening and good day. Thank you all for joining us. It is a pleasure to have you join us for our next Around the Pump ECLS webinar series. It is a great honor to have some esteemed colleagues in the ECLS space joining us this evening to share their experience. A few housekeeping items. We thank you all for joining. We will be taking questions and answers at the end, so feel free to jump in and drop your questions in the Q&A section, and we will answer those at the end of the session. We thank you guys for joining us. I'm going to hand things over to my amazing colleague, Alyssa Johnson. Alyssa is our Global Product Manager for our ECLS and cannula portfolio, and she will introduce our speakers. So thank you all for joining, and Alyssa, thank you for helping moderate this session today.
Thank you, Natasha. So I'd like to introduce our first speaker here. Dr. Kari DiVito is a board-certified cardiovascular and pulmonary clinical specialized physical therapist at J.W. Ruby Memorial Hospital in Morgantown, West Virginia. She is also coordinator of the WVU Medicine Cardiovascular and Pulmonary Physical Therapy Residency and has special expertise in the physical therapy management of critically ill patients. She is first author on the first existing ECMO mobilization guidelines published in the Cardiopulmonary Physical Therapy Journal in 2023. In addition to her full-time practice dedicated to patients on ECMO, she has been a consultant for hospitals interested in implementing WVU Medicine's ECMO team philosophy, cannulate, extubate, ambulate. Thank you, Dr. DiVito, and we look forward to learning from your experience today.
All right, thank you, Alyssa. So yeah, I'm Dr. Kari DiVito, and that was an excellent introduction. And so we're going to talk about our philosophy here at WVU Medicine, which is cannulate, extubate, ambulate, really putting the physical therapist at this profession at the forefront, recognizing how much we have to offer these critically ill patients. And so that's me. Like she said, published the first existing mobility guideline describing exactly how we do what we do here at WVU Medicine. Our program is a center of excellence, and we are a high volume center led by Dr. Hyenga there in that top picture. And so we have had such great success using this model that we have had the opportunity to start coaching other centers and have them adopt our model. And that photo there in the bottom is us actually going around, and we've done some simulation showing how we do what we do with our simulated patient there on the table. But I am part of a much, much larger team. This is everybody here at WVU Medicine. So there are 40 PTs and 33 OTs, and we have a slew of speech therapists and cardiac rehab team members. And we are West Virginia's top-ranked hospital with 675 beds. And while my niche practice is ECMO, we are a stroke center and a level 1 trauma center and a joint replacement center. And so together we do more than 150,000 patient care visits every single year. And we just keep growing and growing and growing. But back to my niche area of practice, I want to call to this reference that was the survey that was done in 2017, where a survey of ECMO centers went out, and most centers didn't really even consider consulting the physical therapist even a few days later. And many, many more don't even consider ambulation as being an option. And so most centers are still keeping patients sedated and are not thinking about what us therapists have to offer these patients. So that tells us that there is still work to be done in this arena, and that's why we're here. So because we have done it here at WVU Medicine hundreds of times with 0 catastrophic events, I wrote it down because the old literature says don't mobilize with the patient on ECMO. It's way too risky. And then some newer literature came out that says this is probably feasible, but you'd need a lot of people to do it. And then there's some studies that say, well, we mobilized a patient or 2 or 3 and nothing terrible happened. And so again, we've done this hundreds of times, femorally cannulated, subclavian, crescent. I mean, regardless of cannula setup, even the ecpella here and there, we are mobilizing with these patients without severe adverse event, contrary to what a lot of people believe. And so I'm very blessed to have the opportunity to go teach and coach other centers to hopefully make mobility with the patient on ECMO the norm instead of the exception. So we have this little decision-making tree. We decide, do we mobilize with the patient? Are they ready or are they not? So I am the ECMO team's dedicated physical therapist. As the board certified cardiopulmonary specialist in the building, seemed fitting. And so that also helps our team establish trust when we're all working together with this population all the time. And so it is so central that the therapist is involved with these patients that the PT and OT consults automatically generate when somebody is cannulated. So every day, if there's a patient on, I will go down to the ICU and have a conversation. The nurse is talking to me about vital sign stability. Have there been any acute changes? Are there barriers to mobility? What's this patient's plan for the day? Are there procedures or tests that might limit what we want to do or when we want to do it? And then the ECMO specialist is talking to me about sweep and flow issues that might be happening, or we might be good to go. And so if we decide that somebody is ready for activity, we decide at what level. Not everybody's ready to jump out of the bed and just walk down the halls, right? And so it might start passively, and sometimes it does, but that's also a great opportunity for me to go introduce myself to this patient's family and do some stretching and joint mobilization to make sure that when this patient's awake and ready to go, that I'm going to be there and they're going to be ready. And it also lets the family get involved with their care if I can teach them to do some range of motion and stretching in between my visits. But this institution has a strong focus on getting the sedation off as quickly as is medically appropriate. And so we quickly progress to seated exercise, working on postural control, standing, ambulating, and then stair climbing, and whatever else this patient needs to do to be able to get back to their life. And we apply this to everybody who is cannulated, because if you were cannulated, you were determined to have some meaningful chance for recovery. So I have worked with anyone from teenagers all the way through their 70s. And it's a good thing that we were so aggressive with our mobilization and our rehab, because WVU Medicine had the highest survival rate of the COVID-19 positive population that needed ECMO in the United States. We had 70% survival. So thank goodness that we got in there early and tried to prevent all the deconditioning that can occur when you're critically ill. And so, yes, we focus on getting this patient back to life, but being active in the ICU prevents so many complications, right? We know that bed rest is bad. We lose 1% of aerobic capacity every day that we're in bed. Muscle atrophy comes on, we get muscle contractures, we get skin breakdown and pressure injury and infection, which leads to a whole slew of other problems. If you're in bed for just a week, your bone density starts to decrease. We have impaired sleep-wake cycles when we're in bed or we're on sedation. Our gut motility is altered. And very importantly, in this population, when we're supine, we have an impaired ventilation-perfusion relationship. And so all the literature indicates that mobilization, ambulation, other PT activities, even if somebody is mechanically ventilated, is safe and it improves functional status and prevents these complications. So all ICUs should be pretty mobile as far as my opinion goes. So we have to implement our ICU liberation bundles and change the culture of our ICUs, which can be hard. The sedatives need to go away because that's delaying this patient's recovery. The vasopressors and the CRRT and the nitric oxide, all the stuff doesn't have to be a barrier. I tell that to my students in the classroom all the time. The stuff is just stuff. We work with it. It's helping us get this patient mobile. And so we can work together to make this patient have an excellent outcome. So your physical therapist, your occupational therapist, we are so much more than that E for exercise in that ABCDEF ICU liberation bundle. We actually affect all of those letters. So for example, an effective way to improve that ventilation perfusion mismatch is to implement a gravitational and an exercise stimulus. That screams physical therapy, right? Patients who are active in the ICU are extubated an average of 1.3 days sooner than those who stay in bed. Mobilizing with patients is also the most efficient method for airway clearance. And in our institution, if our patients on ECMO are not extubation ready by day 4, we do early tracheostomy so that we can get started on that recovery process a little bit easier. Early mobility for all patients in ICU is also going to decrease that ICU-acquired weakness, that risk of contractures that I mentioned before, but they will also increase their likelihood for independent ambulation if they're starting early in the ICU. So we don't need canes and walkers and wheelchairs at discharge. Also, their aerobic capacity is improved compared to those who aren't mobilizing until their floor or step down status. They're actually ambulating an average of 100 feet more on day of discharge than those who had delayed mobility. Those who are mobile in ICU have been shown to require less pain medication. Their gut motility is improved. There's less ICU delirium that they experience, and they have a decreased length of stay by up to 3 days. They're less likely to need readmission. They're less likely to need caregivers. So it's also cost saving. And every patient's favorite outcome is ever needed a chest tube is that if they've been mobile, it's more likely to come out sooner versus if they were not. It is my job to remember that these are people. We are so much more than our professions, right? All of these patients are more than the patient on ECMO in bed 14. And so it's my job to assume the very best outcome for the patients and determine what it is that they need to be able to accomplish from a physical standpoint, from a functional standpoint, to get back to their life roles. And those who are active in ICU report a higher quality of life after discharge and a lower severity of post-ICU syndrome. So again, this needs to be the norm, not the exception. And so even though the literature tells us, well, something really bad might happen if you get them up, it's actually very rare that an adverse event occurs during any PT session in the acute care setting. Like I mentioned, our ECMO program has had 0 catastrophic events. And in fact, an adverse event occurs during 0.6% of all PT sessions in a hospital in this country in a year. And the majority of these events, this institution included, are a drop in oxygen saturation or hypotension. But these issues improve and regulate the more we get this patient moving, the more we reacclimate to upright. And when this patient doesn't have to worry about all of these things happening and everything's beeping and alarming, it's making them worried, they can start thinking about things they want to get back to doing, like caring for their brand new babies, like you can see in the photos. This gal was cannulated and had a C-section with her firstborn baby at the same exact time because her COVID illness was so severe. And so for her, she was discharging into a brand new life role. So we taped blankets together and I put cuff weights inside of them and we simulated carrying our baby around. We brushed our teeth carrying our baby. We picked it up off the floor, or like we're getting him out of the crib, because that's something she was going to have to do for the first time ever in her life. But I could not have done that alone. The key is a team approach. So with our cannulate, extubate, ambulate philosophy, we make mobility everyone's job. Charging just your physical therapist or just your occupational therapist with getting this patient to a full recovery is not possible. If we're all in charge of mobilizing with patients, we get a lot of carryover of our interventions, which allows us to do more patient-specific things like carrying our fake baby around to make sure we can resume that part of our lives upon discharge. So it takes all of us for the motto to work, and we all have a really important role to play. Because of our cannulate, extubate, ambulate, everybody helps approach, we actually had one patient have as many as 57 sessions of activity documented in his chart during his one run. And it does take a village, but we don't function in silos here. You have to change the culture so that nobody says, well, I'm perfusion, it's not my job to help this patient move, or I'm the respiratory therapist, this is not in my realm. We all recognize that this is our patient and we need to work together to do whatever it is that they need to do to get out of here. And so we'll gather, and sometimes we just stand. We're working on pre-gate training. We're working on postural control, balance, whatever it is that this patient needs. Myself and the occupational therapist go in, do an assessment, and then we make a referral to our other teammates of how we believe that they could move safely with this patient when we're not around. Because I recognize that I'm the only person in the room trained to move other people's bodies with my body. And so then I can make a recommendation of, hey, here's how I think this person could safely move with you later. And for that reason, we have patients who we show up and they've already brushed their teeth and brushed their hair and they put their own socks on and they got to the bedside commode with the ECMO specialist and the nurse already before I was even in the building. And so when the team takes over the basic mobility stuff, then I can work harder on the patient-specific tasks. And so sometimes we have to work a while on the balance and how far can they walk? How far do they need to walk? Do they need to climb steps? For example, I had a gentleman who said, I live in a townhouse, and when I come home from work, as soon as I walk through the door, I love to just strip off my work clothes and then they lay on the floor until Friday. And so I just want to be able to take my laundry basket down the stairs, squat down, pick up my clothes, and then take them to my laundry room. And so that's what we did. Cannulated We gave him a basket. We put things across the room on the floor, and we did squats, and we brought steps into his room, and we did the steps carrying our basket so that he could do the one thing that he really cared about whenever he got home. And so some literature has said that everybody who ever goes on ECMO will need post-hospital rehab. But because of the approach that we've taken, we sent 60% of our COVID population directly home. And not because, well, that's what we had to do, it's COVID. It's because that by day of discharge, these patients were getting themselves out of bed, dressing themselves, doing their morning routine. Heck, some ladies stood and did their whole face of makeup. We would walk carrying our simulated babies down the halls and up and down the stairs, whatever it was that they needed to do in their daily lives. And so we sent so many patients home because they were ready. And because of that model that we actually have more nursing-led mobility than therapist-led. I'm only one person, but this patient has a nurse and an ECMO specialist dedicated to them at all times. And so I get lots and lots of carryover of what I'm trying to work on. I lead mobility 90% of the time, but I get so much carryover of my interventions. And that's what makes it possible to send those patients directly home. We have had patients on ECMO out of bed as early as day 1, and we are ambulating on average by day 9. And again, that's regardless of cannula setup. We all work together to get these patients doing what they need. We transition with everyone's help from supine sedated to mobile and moving in the ICU. So this young lady is back to work as a CNA. This gentleman was able to walk his only daughter down the aisle, oxygen-free. And this fellow was able to go to the in-hospital Starbucks before going outside just to have something that felt normal to him. So if you are interested at all in learning more about our cannulate, extubate, ambulate approach, you are welcome to scan our QR code there, where you will see our references regarding that philosophy that we have here and see it from the different point of views of different professions, different parts of the interdisciplinary team. And of course, we'll have questions at the end that I'll gladly answer. Thank you.
Okay. Thank you, Dr. DiVito, for your inspiring presentation. I will be introducing our next speaker. So Lauren Kirkland is an accomplished nursing leader as the ECMO program coordinator at a large academic medical center. With over 15 years of critical care experience, Lauren has built an extensive career in cardiovascular intensive care, specializing in the management of complex cardiothoracic patients and mechanical circulatory support systems. Currently leading the ECMO program, she is recognized for their innovation in education, process improvement, and multidisciplinary collaboration. They have authored institutional policies and clinical guidelines, led simulation-based training programs, developed mobilization protocols, and launched the CVICU New Graduate Bootcamp. Their leadership has significantly enhanced patient outcomes and staff development in high acuity settings. A nationally certified critical care nurse and nurse ECMO specialist with multiple accolades, including the 2025 Excellence in Leadership Award and repeated honors for Best Educator and Most Trusted Resource. Lauren also contributes to national standards through course instruction with ELSO and leadership with AACN. Passionate about mentoring, Lauren continues to shape the future of ECMO and critical care nursing through advanced education, innovation, and compassionate care.
Thank you so much for that introduction, Alyssa. We're going to talk today about how you build a mobility program for your ECMO patients and how we were successful at my institution to do so. So looking at my program structure from the ECMO perspective, we've been around since about 2009. We are a large academic medical center, and we treat adult patients on ECMO. We do more than 100 runs a year. We are also recognized at a Gold Center of Excellence from ELSO. We're also a large volume heart and lung transplant center, and we do a fair amount of VADs over the annual status. We also have a 30-bed CVICU where all of our patients live, and we take care of them with a 24/7 in-house intensivist. So looking at ECMO program leadership at my hospital, it's a shared decision-making structure. So we have a medical director who's a CVICU intensivist, a surgical director who's a cardiothoracic surgeon, a perfusion ECMO coordinator who's in charge of a group of perfusionists that takes care of our ECMO patients when they're in the OR environment. They also help with our stocking and supply of our ECMO patients, and then they serve as CVICU backup for the group of ECMO specialists that care for them in the CVICU. And then I am the nursing ECMO coordinator. I am in charge of all of the ECMO patients when they're housed in the ICU, and I manage a group of ECMO specialists. So the four of us together really have shared decision-making when it comes to ECMO program development, quality improvement projects, and overall patient management. When we look at how we care for our patients when they're on ECMO in the CVICU, it's really a collaborative approach. So they are admitted to the cardiac surgery service, but they are mostly managed by a CVICU intensivist who, again, is in-house and on the unit 24/7. They are also staffed with a bedside RN who is one-to-one with them. And they're also cared with a nurse ECMO specialist. And so that ECMO specialist can take up to 4 pumps at a time. We also have a core respiratory therapy group that's specific to our CVICU. And we also have a CVICU core team of occupational therapists, physical therapists, and speech language pathologists. So all of us working together really try to work as a collaborative team to give our patients the best opportunity to get out of the ICU. And kind of looking at our journey over the last, almost 10 years of our mobility process. So we kind of, like Dr. DiVito stated, started looking to kind of change the culture of our ICU and looking to kind of push for a culture change, specifically in mobility around 2017 and 2018. And then kind of fast forwarding to 2023, we walked our first fem-fem cannulated ECMO patient with the integration of the nurse ECMO specialist onto our care team. So sometimes when you're thinking about, we know that mobilizing patients on ECMO is probably the best thing to do for them when it's appropriate, but it's a very overwhelming process to think about when you're trying to build out a program that's structured and supported for your staff that are carrying out that actual business. So I think about it in 3 big groups. So you want to think about the team, the structure, and the support. So the team is going to be the who. Who's doing the day-to-day work at the clinical bedside. The structure is going to be the process, the way to standardize what you're doing, and to make sure that the same practice is carried out with each patient. And then looking at support. So these are going to be your cheerleaders. And it doesn't have to be just nursing cheerleaders, right? We want to make sure that you have multidisciplinary support and buy-in when you're looking to do this for your ECMO patients. So when you're looking at just the team portion of this, it really can be anybody. At my institution, we didn't have 20, really good input and support with our PT and OT cohort. And so we really had to turn to nursing and say, we want you to get these patients out of bed, even with ECMO cannulas on them. And so really just entrusting the nurses that, at the time were getting patients out of bed attached to ventilators and drips, and they have all these lines and monitoring devices. And so they were used to getting patients out of bed in that state anyway. And so they felt pretty comfortable getting those patients out of bed with ECMO cannulas as well. You want to make sure, though, that in part with that care team that you have somebody who's trained in circuit emergencies. Like Dr. DiVito also said, this is a very rare occurrence, but you need to have somebody who's trained and ready to take care of that emergency when it happens. Also making sure that you're consistent in your process. So if it's, if the team looks like nursing, you want to be consistent in that so that you, again, make sure that you have the same process every time. And this video is one of the first patients that we put on a verticalization bed back in 2018. And he's doing some therapy sessions with our clinical nurse specialist, who's really one of our champions when we were first starting to do this. And when you look at how you want to build structure for your team, we want to make sure that every practice session is safe and is done the way that we're asking it to be done. And so we built out guidelines and policies to support staff in what we were doing. We found that staff was more apt to do things when they're protocolized and structured and they have access to these things. And so we're going to talk through the 3 guidelines that we built out to support the staff in doing those things. So the first was an RN-driven mobility guideline. And so this was really applicable to all ICU patients across our medical center. And it really gave nursing the ability to screen patients for appropriateness to mobilize or not. And so if the nurse decided that the patient was appropriate to mobilize on it or to mobilize in general, they'd consult the ICU team and then proceed with mobilization. And then if during that mobility session, they noted that the patient was, lacking in performance, then it would give them the ability to consult to PT and OT. So in the CVICU specifically, we saw that patients had earlier mobility and had more sessions. And this also was really helpful because it didn't, create a consult for the PT and OT team with every single patient. It really, gave everybody the amount of time that was needed for each patient. So if physical therapy wasn't needed for one patient, but it was needed for another, it allowed that physical therapist the opportunity to spend more time with the patient that really needed it. And then we also built out a mechanical circulatory support policy. So this really gave structure to the management of all of our ECMO and mechanical circulatory support patients. So it outlined the staffing that was required to take care of these patients, what transport looked like both in the unit and outside of that. It also gave guidance to basic assessments that were required for these patients, and then how to manage the devices in general, and also how to deal with some of the alarms that might come through. It also helped kind of structure emergencies that may happen while on these devices as well. So again, serving as a clear resource for the staff that were going to be required to care for these patients. We also built out mobility guidelines for ECMO specifically and Impella as well. And to make it really easy for staff to find these resources, we just put these in the appendices at the bottom of the policy so that staff could go to that mechanical support policy, go to the bottom and find the clear guideline to mobilize those patients on those devices. We also built out a mobility guideline specifically for ECMO. We wanted to make sure that we were very clear in kind of expectations so that when patients were being mobilized by our staff felt empowered to do the same thing and the right thing every single time. And so we clearly outlined the team members that were required to do so. And so we decided to say that, 3 licensed providers, one of which had to be a nurse, an RT, a PT, an OT, sometimes a physician, sometimes an advanced practice provider, and a perfusionist. And so we chose to have a variety of people, as options because we didn't initially have a rehab team to help us. And so we wanted to make sure that patients would be mobilized when appropriate and wouldn't be dependent on a certain profession to be present. We also clearly outlined responsibilities that had to be fulfilled in order to mobilize these patients safely. So one person was responsible solely just for monitoring the patient's hemodynamics. One person had to monitor the ECMO circuit, and one person was responsible for monitoring the patient's activity and tolerance or tolerance to the program. We also clearly defined the process. So we required that either an ECMO specialist or a perfusionist was present at the first mobility session to make sure that there was no issue with the cannula or the ECMO circuit. And we also required that perfusion and ECMO specialists were required for out-of-room ambulation. But again, making sure that this mobility guideline was very easily accessible to all staff so that we had adherence to the process that we wanted for our ECMO patients. Now, looking how you support your staff when you're asking them to do something that they're not comfortable with, really just leading by example, and then finding your champions within each discipline. So finding those bedside nurse champions that were excited to do this and were supportive of their other bedside staff, and so really willing to stand by their side while they're doing this unfamiliar thing that we've asked them to do. We also found a champion in our clinical nurse specialist. She was our biggest innovator for this and kind of brought this to our unit in about 2017. So when we first brought, especially the verticalization bed to our unit, staff was very unsure and very unclear with what we were supposed to be doing. So our clinical nurse specialist was actually at the bedside for every tilt session while we were learning to do what we were doing. You also need physician leadership and physician champions to help support all care members in the team when we're doing this mobility progress with the ECMO patients. You also need leadership to have buy-in. We found that as we're mobilizing these patients, it requires more resources, more staffing, and more support. And so our nurse manager actually advocated to have a resource nurse available on the unit at all times, ensuring that all of our patients who require more mobility sessions were actually supported in getting those sessions. And really just finding your cheerleaders to light the way. Change in practice and culture is something that happens, very slowly over time, and just celebrating the small wins along the way. So we had a lot of success. We had no adverse events. We got really comfortable with getting our patients out of bed. And I attribute a lot of this to the use of the crescent cannula. A lot of our patients, or actually all of our patients, would get cannulated with the crescent. And so we got really comfortable getting those patients out of bed. And over time, staff really bought into the process. They saw, patients being awake and alert and interactive with their family. They saw them going outside. They saw them interacting with their children. We brought, pets in from home. We brought kids in from home. And really, when staff saw the positive things that were happening with the hard work they were doing, that's when we really saw the culture change. And so we were just really proud of what staff was doing, and really, all the hard work was starting to pay off for these patients. And then we all remember COVID kind of changed everything for everybody. We kind of had to shift our mindset. We were used to using the tilt bed that was brought to our unit, a couple of years before, to really strengthen the patient's legs, to work them to getting out of bed and walking down the hallway and eventually walking home. And so COVID kind of changed all of that for all of us. So it really had us, caused a pause for all of our care teams. We had to redefine kind of our goals and our process when we couldn't wake our patients anymore, when we couldn't walk them down the hallways, when we couldn't lift sedation to do those, SATs and SBTs. And so we kind of had to shift what we were doing. And so we looked really to what we knew which was successful, and that was the tilt bed at the time. And so recognizing that the tilt bed kind of had more indications than what we thought. And so what we found was that when patients were even sedated and paralyzed, we would still do our verticalization sessions. And we saw that their blood gases were better, their saturations were better. And so we found that really, instead of where other centers were proning their patients for acute hypoxia, we would do emergency tilt sessions. And so if our patients decompensated from a respiratory standpoint, we would tilt them to 30 degrees and we would get better oxygenation. And so we really saw the pulmonary benefit that may be coming with these verticalization beds that we weren't aware of before. And so kind of throughout the rest of COVID, we actually ended up keeping our patients upright at 30 to 40 degrees for sometimes 60 to 90 to 120 minutes. And we really saw the benefit of that. So because of what we learned during COVID, it kind of opened our eyes to other positives that may come from verticalization therapy that we weren't aware of before. So prior to COVID, we really just used the tilt bed to kind of strengthen people's legs and get them walking down the hallway. And now we saw that there was pulmonary benefit from that as well. And we also saw a lot of improvement with our delirium management from the verticalization sessions that were occurring. And so we kind of opened up our indications for patients that we were putting on the tilt bed. And so we started to really think outside the box and shift our way of thinking. Initially, we thought more so like, who are the patients that are appropriate to tilt? And that kind of shifted to really, who are the patients that can't? So really trying to make sure that we're including all of our patients when we're thinking about verticalization therapy and mobility. So with this expanded group of indications for verticalization therapy and mobility, we really wanted to give more structure to the nurses that were trying to decide if the patient was appropriate for sessions or they were not. And so when we're thinking back to the guidelines that we had written for all of our ICU patients, we really wanted to be more specific, especially for our CD ICU population. And so we built this stoplight looking guideline to make sure that it was very clear and evident for everybody who was looking at it, kind of indications as to do therapy or not. And most of our patients tend to fall right in that yellow, and that really asks everybody just to pause and talk to the ICU team before you do a mobility session. And then if it's appropriate, just go low and go slow. So really, again, making it just very clear for everybody who's doing these sessions for the patients, so that we're all doing the same things and using the same expectations. And this discussion of if the patient's stable or not to do mobility sessions really starts on our morning rounds. So we, right around shift change, do a mobility round, and that includes the PT, the OT, the bedside nurse, somebody from the ICU team, and we all come together to define a mobility plan for the day. So really to plan out the day, kind of decide if there's anything going on that may hinder a mobility session, and see maybe barriers for the rest of the day. So we also wanted to support the enhanced, really just keeping mobility at the forefront. So if we're asking more mobility sessions, with more frequency for more patients, we want to make sure that all the care team feels supported in doing this mobility sessions. So we really wanted to be specific about titrating the mobility process as well. So we looked at 4 different variables when we're looking at our mobility session. So the patients are going to be specifically watched with their blood pressure, their heart rate, their pulse ox, and just overall fatigue. So for example, if I'm tilting my patient and I then get hypotensive, I'm going to, instead of stopping the mobility session at all, I'm just going to drop that angle of tilt 5 degrees, and then I'm going to watch and wait for 2 minutes. If my hypotension still hasn't resolved, I'm going to drop another 5 degrees and watch and wait for another 2 minutes. If my hypotension still hasn't resolved, then I'm going to stop the mobility session. So really, we're keeping mobility at the forefront of our mind and really giving the nurse or the care member really the ability to titrate the mobility as the patient is tolerating. And that guideline also included hard stop criteria. So if we had, for example, ECMO low flow for greater than a minute, or if we had suction events on our Impella devices, or the patient was so agitated that it was unsafe, that really gave the care member or the nurse the ability to stop the therapy session. But at the end of the algorithm, it always asked to have a reassessment within the next 4 to 6 hours. And that really set the cadence for what our expectations are now when we come to mobility sessions throughout the day. So that includes a morning AM PT session where the patient gets edge of bed, out of bed, or mobilizes in the hallway. And then we do an afternoon session where they at least verticalize, if not get out of bed again. And then we do a tilt session before they go to bed. So that's going to help with the sleep-wake cycle and help with delirium prevention. So what do we do when our patients are too unstable for an out of bed, edge of bed, or a full mobility session? And this is really where we saw the tilt bed to really help support us through this while we're navigating the patients being too unstable to do those things. And so we saw a lot of benefit in using just a slow session with a low angle. So really only 30 degrees. So we'd strap the patient in, only tilt to about 30 degrees. And we saw a lot of benefit from that instead of doing the full mobility session that they weren't ready for that day. And so with that session, we saw the training in the baroreceptors, and that's going to prepare the patient for the edge of bed sessions and try to prevent orthostatic hypotension. We also saw that even with the lower angle tilt, the 30 degrees, we still offload about 20% of our body weight onto our legs. So we're still activating those muscles in our legs that are going to strengthen them and prepare them for the mobility sessions that are coming next. We also saw that even, again, with those low tilts, we're still activating their brains. We're still, putting the TV on. We're having family come and interact with them. We are having the lights turned on. We're talking to them, doing passive range of motion. So again, trying to prevent delirium. And then kind of through all of that, we really saw that we should be individualizing our verticalization targets. So if we see a patient who really needs pulmonary help, we're going to tilt that patient only 30 to 40 degrees, but for a much longer time. So 30 to 60, sometimes even 90 minutes. Or if we're going to shift our focus and say, we really want to get this patient out of bed and walking, we're going to focus on the rehab and the muscle strengthening. We're going to tilt that patient at 60 to 90 degrees in the bed, but maybe only for 5 to 10 to 15 minutes at a time. So really individualizing what we're doing with the verticalization therapy. And just recognizing that mobility on ECMO is really a collection of all of these things. So mobility is more than just one session. So we don't just mobilize our ECMO patients one time a day, it's now 3 times a day. And that's the expectation, that's the norm. That's what all of the care members know. That's really what's happening when you're caring for an ECMO patient now. This mobility on ECMO is supported through the A to F bundle, right? We want our patients on less sedation. We want them awake, walking around the unit. We want a family at the bedside feeling like they have a say and really a part in their patient's care. We want to make sure that there's structured support. So again, showing transparency to people that you're asking to do this at the bedside every day. So making those policies readily available, making sure they feel supported and feeling like they have a voice if they feel like something that's written down is unsafe, or that the process that they're doing maybe has some gaps that we need to, focus in on, work on. And recognizing too that this, mobilizing somebody on ECMO is really a team effort. It's not just nursing doing it. It's not just therapy doing it. It's really us coming together as a team, really just to trying to get our patients back to home. And recognizing that sometimes you have to fall back on the pre-mobility. All of our patients go on a tilt bed from the start, so that those days when they're either too sick or too unstable or just can't do a full mobility session, we don't fall behind, and we do those smaller pre-mobility sessions that are going to hopefully optimize their mobility the next day. So we felt really, really comfortable with, mobilizing IJ cannulations. And so we saw that it was safe, it was doable, staff felt very comfortable with the process. So why should we exclude patients if they're awake and ready to get out of bed, but they just have a femoral cannulation? And so why would we want to subject them to go into the OR, getting a new cannulation strategy and going under another procedure? And so we shifted our mindset to mobilizing those patients instead of moving their cannulation sites. And so we came together with the medical and surgical directors of the program, myself, and my PT and OT group in the CVICU, and we established a process. So that includes using the tilt bed. And so what we'll do is we'll grade their muscle strength. We'll tilt them to 90 degrees and have them do mini squats. And if they tolerate that, then we'll have the ECMO specialist do a site assessment where we do a hip flexion test to 90 degrees. And we're testing the ECMO cannula site, the sutures, and the ECMO flows while we're doing that. And then if all of that's good, the patient gets up and starts walking. And we've had really good success with that, and have had no adverse events. And so because we really expanded, the expectation to all ECMO patients mobilize, however their cannulation strategies look, we really wanted to make sure that all members of the care team were educated and felt comfortable in the process. So I started working with the PT and OT group to really build out a competency for the PT and OT team. And this competency was had multiple strategies. We use a didactic component where we reviewed ECMO terminology, circuit terminology, and some of the basic settings that they were going to see day to day, and the different cannulation strategies that were going to be used. So really, when we're talking as a team and coming up with a plan, we're all speaking the same language and we all understand what we're all saying. It also included hands-on training where I did a circuit review with all of the PT and OT groups and making sure that they felt comfortable touching the ECMO circuit where they were allowed to and making sure they knew the components that we were talking about. This also included 2 different simulations, one with an IJ cannulation and one with fem-fem cannulation. We also included an emergency scenario so that they knew in that situation what their responsibilities would be and what that scenario would look like. And staff really perceived this very well. They felt more comfortable going forward with mobility sessions, and now it's an annual competency for all of our staff. So kind of where we are now, this was 7 years in the making. That definitely wasn't always an easy process. But where we've shifted our mindset to now is that patients automatically go on a verticalization bed, meaning if I have somebody coming from the outside on ECMO, they're going right onto a tilt bed. And we start ECMO mobility day 1 if they're appropriate. We try to avoid intubation when we have a scheduled cannulation when possible. And if we can't avoid it, that's the first thing we're thinking is, get that patient extubated so we can get them up and moving. If we have a patient that, came from the outside really sedated, as soon as they are able to open their eyes and track around the room, we engage OT to try to help with that cognitive stimulation and try to prevent delirium. We also engage our PT friends when we are able to have that patient lift their head off the bed, try to get them moving as soon as they're ready. We also do daily mobility rounds. That's multidisciplinary. And we kind of set the standard for what the patient's going to do for the day from a mobility standpoint. We mobilize our femorally cannulated ECMO patients, and early ambulation really has become the norm in the CVICU. It's not the exception. We've built out an annual competency for our PT and OT team and built out an ambulation simulation in the CVICU ECMO course. And so that ECMO course is attended by all members of the team. So our bedside nurses, our respiratory therapists, our advanced practice providers, and our physicians. So everybody's on the same page. And what we've learned, recognizing that really mobility can start before the patients are really awake and oriented. So how do you go from, the patient's sedated and paralyzed in the bed to up and walking in the hallway? And we really found that verticalization therapy can bridge the gap for the patients. And building a structured foundation to start is really going to help your staff buy in and really understand what the expectations are when they're doing something that they're not familiar with. And again, finding your champions, finding your cheerleaders to be the light for something that people are uncomfortable doing. And just recognizing that this is definitely a marathon and that buying is not going to happen overnight. Mobility takes a team, and I'm definitely proud to share, our process throughout this whole journey that we've been on. So thank you.
Awesome. Thank you so much, Lauren and Dr. DiVito. It's a pleasure to have both of you and sharing very unique perspectives, both from the PT and from the nursing perspective. We have some great questions that are starting to come in for the audience, so feel free to continue to drop your questions in, and we'll try to get to as many of those as possible. One of the first questions we have in, both of you were talking about ambulating your patients, especially with IJ, but also with femoral cannulation. And so one of our customers, Ryan, is asking about how do you overcome the barrier of mobilizing a VA patient, particularly those that are femorally cannulated. So Lauren, I don't know if you want to start with that, and then we can switch over to Dr. DiVito.
Sure. So I think mobilizing any patient with femoral ECMO is scary for people who don't do it every day. So the way that I got staff to buy into that was I took responsibility for it initially. So I was present for every single bedside session that happened. And over time, staff just get confident seeing that, this is a safe practice. We can do this. And so just over time, people buy into it when they know that they're safe to do it.
Yeah, I completely agree with that. And Lauren touched on this too, at how they test, if somebody has a femoral cannula, they're doing that test, flexing the hips, seeing if any change in flow happens. We don't use the tilt bed here at our hospital, but we will either use chair mode of our beds or sit the patient edge of bed, because that is the greatest angle of hip flexion that patient's going to achieve during the session. Whenever they're standing, hip not flexed. When they're walking, hip not that flexed. And so our assessment is done while the patient is still very near the bed or in the bed, so that if there is a disruption of flow, then we can get them back to the supine position pretty safely, very quickly as well.
Awesome. Thank you both. And along those same lines, another person is asking about, what do you guys use to secure those femoral cannulations? So is there any specific tools or techniques that you guys have to recommend securing femoral cannulation?
Sure. So we, when the patient is cannulated, we secure with at least 3 sutures on the cannula itself. And then we use a Hollister securement device on each limb of the circuit.
Yeah, our institution used to do more sutures, but now I don't know that it's the technical name for it, but they are calling it like a pancake dressing that has the securement that goes around the cannula, and they do that every 10 centimeters.
Okay. So I'll answer the next question we have on here for both of you. So how do you feel about ambulating while intubated?
So I think just like anything, when you're doing something that you're not familiar with, you really support your staff like side by side to do it. I have no concerns with ambulate or with getting anybody out of bed with a breathing tube or a tracheostomy. We do that kind of as our norm. And so again, I think when you're starting this, from the ground up, really just being side by side with your staff to support them in something that they're not familiar with.
Yeah, so I mentioned that we do early tracheostomy here at WVU Medicine. And so I mean, the vent comes with us, the nitric oxide comes with us. And again, like she mentioned, the first time is scary, but once you do it successfully, even if it's not a trach, even if you are intubated, it just takes the getting used to. And again, the staff seeing like, oh, okay, that wasn't so bad. Nothing bad happened, and you just build that rapport within your team.
That's really helpful, Kari and Lauren. Thank you for your answers on that question. I know you had spoken to Kari, different the incidences of accidents in the US. And one question that we have related to that is, who is the person trained in ECMO emergencies at your hospital? Is it the ECMO specialist or the bedside nurse?
So all of our ECMO specialist would be the one who takes charge in an emergency situation prior to, an APP or the MD arriving to the situation. But we have written checklists that comes on the ECMO pump. And so that if there is a situation, the ECMO specialist, in a moment of panic, you're not thinking your clearest. And so it's like, all right, I need to check this, and this. Respiratory, go through your checklist. And they have their ECMO checklist on the vent in the room. And so that if that's with us, say, okay, I need to check these things. And the nurse has a checklist. What might be going wrong? And I know that my job is always to keep this patient safe, prevent a fall, and then the ECMO specialist takes over as the team leader in an emergency.
Awesome. Lauren, do you have the same? Is it your ECMO specialist that kind of take charge in an emergency?
Yes, but we actually put our bedside nurses and our respiratory therapists all through an annual competency that includes emergency, so that if the ECMO specialist is working on part of that emergency, all members of the care team have the same understanding as to what's going on and are prepared to support the patient through that.
Awesome. Some more great questions are coming in, guys. The next question that we have is, what strategies have you found most effective in gaining and maintaining provider buy-in for early, mobility and ambulation, particularly in addressing some of their concerns about safety, staffing, and workflow integration? You talked about having those champions and cheerleaders, Lauren, and I think Kari, you also mentioned that, but how do you keep that and maintain the buy-in from the providers?
I think once you change the culture and the mindset, that just kind of takes on a mind of its own. And staff see the success that happens when you get these patients out of bed and walking around the unit. And so really kind of takes on a mind of its own. They see that patients are doing better getting out of bed. And so you don't need somebody to be cheerleading for it. The positive outcomes are cheerleading for themselves.
Agree. Like, your outcomes will speak for themselves. Absolutely. I was really fortunate where the surgeon came to me and was like, I'm going to start this program, and I want these people to move. And so the buy-in was there, but the literature wasn't there to support us, so it was kind of a trial and error. What's going to work for us until we had this really smooth system, and then everybody sees it working. And actually, like, doing a therapy session with a patient on ECMO is one of my more efficient sessions, because there's so many people involved and everybody knows what their role is. And so if we set a time and we're like, we're going to do some PT at this time, and everybody shows up and is a team player and sees how well oiled we are, and everybody's like, yeah, this is just what we do here. This is normal. Everybody should be doing this. And now I have nurses who have gone to other institutions and are reaching out to me and saying, they don't do that here. How can I help advance practice here? And so I'm sending them our literature and our videos, and how can we help? And So I'm so thankful that we've had the chance to do some teaching at some other medical conferences and some simulation events at other conferences to help get that buy-in at all these other institutions.
Yeah, great call out. And that's one of the next questions that I have. And I know we're getting close to overtime, but I do think there's a couple more questions that would be great to get your guys' perspective and buy-in. So I've heard this quite a bit from institutions that we've engaged with. And so one of the questions that are coming in is, how does a facility that intubates, sedates, and has zero mobility with RT ECMO specialist at the bedside, do you guys have any recommendations on to where they even should start to get kind of their process for early mobility? I think it is a huge step to go from completely intubated and sedated with zero mobility to seeing your guys' patients that are eating Starbucks and are out walking around and, you know, fake boxing and et cetera. So any suggestions for those members that are listening in that have no mobility in their programs?
I definitely have a suggestion. So our CVICU is very mobile, you know, all patients out of bed multiple times a day, regardless of ECMO, not ECMO, whatever it is. But the culture is different from ICU to ICU just in this building. And so what we had to do that helped tremendously is we started a mobility round. And so, you know, it was twice a week where we got a physician who bought in, and we would go around whatever unit we were working on at the time and say, okay, here's this patient in bed 1. Or what are the limiting factors to their mobility? You know, how could we have made them more active? What are some of the benefits of them being more mobile? And so we had this interdisciplinary team that went around to all these patients, and nurses got to see, you know, the process and think, oh, I guess they could have at least set the bed, you know, the head of the bed up today, or they probably could have gotten to the chair today, you know. So we had to do some of that convincing. But as we did the rounds every single week, we started coming around and seeing, well, the nurse got them out of bed already. You know, oh, they actually walked to the bathroom with the aide today, because we realized, why not? And so it took us a while going around and having that discussion of why not, but it so changed how we move in our ICUs here, you know, regardless of their diagnosis.
One question kind of building on this last one that we have from the audience is about frequency. So how often are you typically able to provide physical therapy and occupational therapy interventions for patients on ECMO? And what factors most influence the consistency and frequency of those sessions?
So I would say that 100% of our ECMO patients get at least 2 sessions a day of actual out-of-bed therapy, and then they get a tilt session before they go to bed. And really, that is independent of if we have a physical therapist or an occupational therapist on the unit. That is an expectation of nursing staff. And so, but really that, you know, that takes a lot of time and a lot of support for your staff and a lot of, you know, setting expectations. But really that's the expectation for all of the ECMO patients now.
Same here. The expectation is that these patients are out of bed every day, that they are critically stable, as we call them. But from a rehab perspective, our center has capacity for 6-7 patients. And so if we have that many on, and we have, I can dedicate my day to that. And I can dedicate every day to that. So in West Virginia, we have a lot of comorbidities and obesity and lots of chronic lung and heart disease right here at home. So these patients really need me. And so we have a team of therapists that are on each unit. And so if I need to dedicate more time to the patients who are on ECMO, I know I have backup teammates who can help me out and, you know, go see these other other individuals in our unit. There will always be more patients than therapists to go around, though, and not everybody is considered stable every single day. And so that's why I go around and have that conversation with the ECMO specialist and the nurse to decide who's going to get the most benefit from what I have to offer at this time.
Awesome. I love the approaches both of your centers are taking. And for those on the audience, don't be discouraged. It took a lot of work for them to get to where they're at today. And, you know, starting with those baby steps. And, you know, I know a lot of us are here at AACN, and a lot of the nurses are starting to talk about tilt beds and are starting to talk about their critically ill patients and getting them moving. And so I really think that individuals like Lauren and Dr. DiVito are really going to help shape the future, especially for our ECMO patients. Lauren, we did have a question that came in, and curious if you're interested. They're asking about the policies, if you'd be able to share your policies with them. They're having some roadblocks in getting their policies approved. So not sure if that's something that you're able and willing to share with some of the audience. If you are, we could definitely get you in contact with those individuals.
Yeah, I mean, I'm happy to share my contact with them, and we can set up time to talk through things, and we can, you know, I can try to help guide them in the right way that, you know, we overcome those obstacles when writing policies as well.
Awesome. And I know, Dr. DiVito, you shared your QR link. We'll make sure that that's available for all of the attendees. I apologize. We're, you know, over time by a little bit, and we appreciate all of you guys staying on. We will make this webinar available online here, hopefully shortly. I also want to apologize. I got some messages coming in from some of you that the audio and video was a little bit laggy. And so I do apologize for that. Again, in our final version that we'll put up online, we'll try to make sure that we get all of that taken care of. If we didn't get any of your questions answered, please feel free to reach out to your local Medtronic rep. We can work to get you in contact with both Dr. DiVito and Lauren, and really help advance your guys's practices. It's a privilege to be part of your guys' ECMO care and to be part of your team. And we really just want to thank both Lauren and Dr. DiVito for sharing. Their centers are definitely at the forefront of this. And we're so grateful that you're willing to share with the audience and really help advance ECMO patient care for those. So thank you everyone for joining us. It was a pleasure, and have a great night.